Well, welcome everyone. I'm so happy to have the opportunity to talk to you about a topic that's near and dear to my heart. So my name is Dr. Lisa Larken. I'm a women's health internist in Cincinnati, Ohio. And I'm going to talk to you today about menopause management. And this is specifically in women when hormones aren't an option. So hormones are the most effective therapy for hot flashes, but obviously there's many women who can't take them. So I'm a clinician, and so you'll see that we're going to go through cases and talk about this. So the objectives for today, we're going to talk about menopause-associated symptoms and physiologic changes that happen during menopause. And if any of you gone through menopause like I have, you know that those physiologic changes are real. I'm going to talk about options for managing menopause symptoms when systemic hormones are contraindicated. And at the end, I'm going to talk a little bit about something else, which is management of sexual health after menopause in women who, in general, can't take hormones, and talk to you about the difference in the data. So as I said, I'm an internist, do women's health. I have both a primary care practice and a consultative women's health practice. I do a lot of cancer survivorship work. And this is a pretty typical patient for me. This is Karen. She's 49 years old. She has a history of breast cancer. 3 years ago, at the age of 46, she turns out that she's BRCA positive. She had her ovaries removed at age 47 during her therapy, and now she has had 18 months of severe hot flashes and night sweats, and she is postmenopausal by definition. She's also having severe vaginal dryness and pain with intercourse. Her current medications are Tamoxifen, and she tells you that she's absolutely miserable. And if any of you are suffering from hot flashes like I do, I'm a breast cancer survivor also, they can be quite disabling. So this is a patient that I see in practice, and the question is, how can I help Karen, with both her hot flashes and her vaginal dryness safely? So menopause. So lots of great cartoons out there, lots of jokes about women who are going through menopause. And I really like to focus on the fact that one of the things that's happened in the space of women's health is we know that, for all of history, we've really approached women and women's health through the wrong lens. And what do I mean by that? Which is, for almost all of history, women were assumed to be different than men just because they have reproductive organs. They were considered a smaller version of men. So any illnesses, diseases that happened in just women, there's been this hysteria narrative, right? That women just are emotional, and there's been all kinds of therapies directed at treating things as a psychiatric condition without ever really having the lens that women are unique and different down to every single cell in their body. And the impact of hormones that are so different in women than men have a huge impact on diseases, but also on symptoms. And so menopause is a time in a woman's life, you all probably know this, when the ovaries basically become quiet. You are no longer fertile. And one of the things about humans is that we are one of the few species that have a significant span of life after menopause, after we no longer are able to bear children. And that's uncommon in the rest of the species. And so we are unique in that we women in the United States are spending about a third, maybe even a little bit more of their life as postmenopausal women. And the difference in the hormonal milieu of the body, premenopausal and postmenopausal, is huge. And the big difference is this huge change in estrogen. Other hormones change as well, but the impact of that on physiology and aging in all kinds of arenas is huge. And women, definitely the majority of them, are symptomatic. And so when does that happen? Well, the average age of menopause in the United States is 51. And what that's defined as no menstrual bleeding for 12 months. So a blood test does not define menopause. It's no bleeding for 12 months. And the perimenopause transition is when, in the 2 to 6 years prior to that final menstrual period, when the ovaries aren't producing eggs normally, fertility drops way off, the quality of the eggs are poor, women don't ovulate every cycle, and hormone changes begin. And it really is a time when women often become, even before their final period, they are very symptomatic with hot flashes and night sweats, and lots of times vaginal dryness, and can be anxiety, sleep disturbance. And it's really a bumpy ride. The final menstrual period, you can only really know in hindsight. You have to get 12 months without any bleeding to know that you're menopausal. And again, that age is typically in the United States right around 51, although it's a bell-shaped curve. And I certainly have patients who don't become menopausal until 55 or 56. And so again, the symptoms are real and there's a lot of them. So related to these big swings in hormones and drop in estrogen level, women can have severe anxiety, depression. It can be the first time that they have mood disturbance in their life, and associated hot flashes, and night switch, which is the thing that many women directly associate with menopause. And what's happening is what I just explained. So if you look at the top, when you are a 20-year-old and you're having regular menstrual cycles, your hormone levels change day to day, but it's a very consistent pattern. And women typically know that their cycles are 28 days or 26 days, and it's really consistent. In that perimenopausal period, we call it puberty part 2, hormones are all over the map and women feel this. So even though they're still having periods, women are having high levels of hormones and the next day very low, and they bounce all over the place. And so some months women will have breast tenderness and heavy bleeding. Other times they will have anxiety and light bleeding or no bleeding, or their period will be delayed. And every woman transitions somewhat differently. In the postmenopausal period, hormone levels are low, but they're consistently low. And so in general, what I tell patients is for the majority of women, but you'll see not all, once you're on the other side of menopause and your hormone levels are consistent and stable and low, you start to feel much better again. Now, there's lots of barriers. We know that menopausal women are not getting appropriate care. Largely, we know that cancer survivors, and this patient, for example, for menopausal care, we know that cancer survivors suffer in silence and get terrible menopausal care. And that's because there's a couple things going on. One is that, there's this messaging that, menopause is a natural transition, so there's nothing wrong with you. And the other is, this hysteria narrative. And my husband, tell you an anecdotal story. I'm a breast cancer survivor, as I said, and I can't take estrogen, of course, and am on one of the medications I'm going to talk to you about to treat my hot flashes. I decided to try going off it at one point, and my hot flashes were just disabling again. And my husband one day looked at me and said, if men had the severity of symptoms that you women have, we would have found a cure by now, because, it really can be quite disabling. And what are hot flashes? So that's what we're mostly going to talk about today. So these are, and I think the picture describes it well. I have a friend who used to stick her head in the open freezer. She would get these sudden surges. And I can tell you that's what it is. I describe it myself as just having absolutely no ability to regulate my own body temperature. I go from hot to cold all the time. And anyone that sees me lecture or is in a meeting with me, or patients will see me, that I take my lab coat off, my sweater off. I'm always carrying things, and it really is annoying. Even on medication, I still have them, although they're vastly better. They occur in 50 to 85% of women. And as I mentioned, they really start prior to that final menstrual period in the perimenopause. And they typically extend beyond 1 to 2 years beyond that last period when they're the most severe. Now, the average duration for most women are 7 to 10 years, although many women have them much longer, and many women, about 15%, have them throughout their entire life. And we know that they impact sleep, they impact mood. And I'm going to tell you, they do some other things as well. They're not just benign. It's not just that you can't regulate your temperature. They're associated with other disorders as well. And they're more common in African Americans and Latina women. And what's the cause? So it's only recently, this is, thanks to good science and research, do we have a better understanding with what's happening with hot flashes, but it clearly correlate with the decline in estrogen level that happens around the time of menopause. And what a hot flash is again, it's the way I describe it, which is no ability to control my body temperature, which is that in the part of the brain that regulates temperature, it just isn't working well. So small changes in core body temperature cause either sweating and flushing or chilling. And it just is this cycle. And we now understand that there really is a specific part in the brain where the temperature regulation happens that is not working correctly. And now, and this is important because there's some drugs, new medications coming up the pipeline that we've learned about specific nerve pathways, and it's these things called candy neurons. And you'll just may hear that in the future if one of the drugs actually comes to market and becomes FDA approved, but it's a specific problem in the brain that leads to triggering of the hot flashes. There's also changes in serotonin, and what also happens is that women don't have good vascular regulation anymore. So blood vessels constrict and relax and constrict and relax. And this is one of the reasons that we believe, and there's some association now, that hot flashes are associated with heart disease and osteoporosis. So it's really emerging data, but in women who have the most severe hot flashes, we think that that's a marker for earlier cardiovascular disease, and that there's something they have this autonomic dysregulation, and there's some abnormality in their vasculature, which makes them more prone to cardiovascular disease. What the sad thing is that the vast majority of women who are going through menopause who are having these terrible symptoms are untreated. And that's because there's confusion and lots of misinformation out there about the safety and efficacy of hormones. Now, again, in a breast cancer survivor, it's not up for discussion about hormones, but in the non-breast cancer survivor patient, the vast majority of patients are really good candidates for hormones, and that the benefits really outweigh the risks. There's also confusion about non-hormonal options and reluctance of physicians, frankly, to prescribe any medications for hormones. I can't tell you the number of women that come to see me for a consult who say, yes, my primary care doctor or my OBGYN said, my symptoms aren't that bad and I should just kind of get through it, that they will get better. And again, I told you that 15% of women, their hot flashes last their lifetime. And I can tell you personally that they're really disabling when they're severe. And so what we know is what I just said, 20%, really 75 to 80% of women are not treated. And so this is 3.7 million women, and that's a low estimate. So if we take 60 million women between 45 and 65, 20 million of those are postmenopausal. Of that, if we say that 25% of those women have very severe hot flashes, we know that only 20% of those women are treated. And that's one of the reasons I do what I do, because there are definitely women suffering in silence. And this is a slide just to remind everyone that what do we know about women, which is that women are not all the same. And so cookie cutter approaches to menopause, or frankly, I did another lecture this morning on breast cancer risk assessment and mammography. So screening women for breast cancer shouldn't be the same. Treating cancer survivors should not be the same. Managing menopause and sexual medicine really needs to be individualized. And it really is called shared decision-making, really has to come into, all of the factors of a woman's health that has to influence the decision about what we talk about for treatment options. So again, just to comment that hot flashes, the things that increase the severity or influence the severity is family history. So if your mother had bad hot flashes, you are likely to have bad hot flashes. If you had symptoms during the perimenopausal period and were having hot flashes, you're likely to have hot flashes that continue after the final menstrual period. African Americans are more severe. Weight impacts hot flash severity. The suddenness of menopause. So if you have surgical menopause or chemotherapy-induced menopause, your symptoms tend to be worse. Smoking definitely makes hot flashes work, as does alcohol intake. I can't tell you the number of times I've had women say, it's really weird, my hot flashes and sleep disturbance are so much worse on Saturday and Sunday, and I don't know why. During the week, I tend to do better. And it often, if you take an alcohol history, it correlates with alcohol intake. What we know that out of 100 women, again, every woman goes through menopause differently, about a third, it's a third, about a third of women are like, I don't know what the big deal is. It's not really that bad. Yeah, maybe I get a little bit hotter and I kick the covers off at night, but it's not a big deal. 36% of women have moderate symptoms, and then 30% really fall into the category where I fall into, of really disabling hot flashes that really impact quality of life. And we know that again, cancer survivors that have chemotherapy or surgically induced menopause tend to have more symptoms. The other important thing to know is that with menopause, hot flashes are not the only problem. So you can see the peak there in the purple is that hot flashes cluster around that final menstrual period. So we say the 1, 2, 3 years before the last menstrual period to the 1, 2, 3 years after the final menstrual period is when women are most symptomatic. You can see on the far right, though, the green line, the difference is, in general, the sexual dysfunction related to menopause doesn't start so early. So we know that it really is something that is progressive and it happens much later. So oftentimes women's hot flashes go away. They think that they're done, they're feeling fine, and then they start having sexual dysfunction, and they really don't have any understanding that the sexual dysfunction is still related to menopause or that there's treatment. So just like I said, with hot flashes are really undertreated. We know that really only 7 to 9% of women who are having sexual dysfunction related to menopause that's easy to treat ever get treatment. One of the big reasons that women are not being prescribed hormones, even when they're good candidates for hormones, is because of the Women's Health Initiative data. And this was the amazing news coverage that happened in 2002. And although this is almost 20 years ago now, the impact of the Women's Health Initiative data on healthcare of women has had profound and sustained effects, even though the data that you see on this screen, 25% increased risk of breast cancer, 30% increase in heart disease, and 40% increase in stroke. That data those are true statements, but the way that it's portrayed in the media, women, when they saw that 25% increased risk of breast cancer, interpreted that to mean that if I took hormone therapies, I now have a 1 in 4 chance of getting breast cancer instead of a 1 in 8 chance of getting breast cancer. And that's not the way that is. The 25% increase is one extra case of breast cancer in 1,000 patient years. And when you look at the risk of breast cancer hormones, I can tell you it's a number that says relative risk of 1.2, but that's equivalent to eating a high-fat diet or being overweight or having increased breast density or drinking more than 3 alcoholic drinks per week, right? So the risk is real and measurable, and we have to talk about it, but relatively small. And so again, in breast cancer survivors, I'm not advocating taking hormones at all in this patient, but just planting the seed that many women are excellent candidates for hormones, and we know that the vast majority are not getting them. But in this patient, our breast cancer survivor, we don't use hormones. So on the left, there's 3 categories of medications, 3 categories of treatment options for hot flashes. The one on the left that says hormone therapy, we're not going to talk about that today, but you should know that that is the most effective therapy, and most women really are good candidates, of course, not cancer survivors. So in our patients where really there's a contraindication due to a prior stroke or a clotting disorder or breast cancer, non-hormonal options, prescription, are available, and we're going to go through those. And then there's a whole bunch of what we call complementary and alternative medicine things, supplements, lifestyle habits that we'll talk about, and then wearable devices. So the North American Menopause Society, an organization that is the leading women's health organization in the country. It's actually an international organization. I'm very honored to be involved with the North American Menopause Society. I currently sit on the board. It's been my medical home for the last 25 years of my professional career. And this is, NAMS has the published guidelines in the space of women's health. And this is their position statement. It's just about to be updated. 2015 is a little bit old for a position statement. And we are working on it now, so that will be out sometime next year. But this is the most current kind of guideline. And so the things that are recommended, that's FDA approved, there's only one FDA approved non-hormonal product, and that's paroxetine, which is an antidepressant. There's other off-label antidepressants that have data that are very helpful, but again, they don't have the FDA indication, and that's not uncommon for us to use things quote unquote off-label. There's gabapentin and clonidine. There is some benefit from cognitive behavioral therapy and hypnosis. There's less data about weight loss, mindfulness, a supplement called S-equal, and something called a stellate ganglion block, which I'll show you. There's really not great data about exercise, yoga, paced respiration, acupuncture, chiropractic, and all the other supplements. Although I will tell you, I'm not sure I can ever say that it's bad to recommend exercise, yoga, paced respiration, acupuncture, or chiropractic care. I mean, people get benefits. And again, even without data, I don't push people to do this and tell them that that will necessarily help their hot flashes, but I don't discourage them either. And then there's several other things. There's oxybutynin, which actually is the medication I'm on that didn't have data when this publication came out in 2015, but it does now. Depo-Provera is something that can be used. And then what's coming up the pipeline are these things called NK3 inhibitors. And that's, I mentioned, these are targeted therapies in the brain that have promising data. And hopefully the clinical trials will continue to progress, and these will be available soon because there's certainly need. And I say all the time, I'll be the first one to try it. So paroxetine is goes by the brand name Brisdel, and it's the only, as I showed you on there, non-hormonal medication approved by the FDA. It's been available since 2013. It's an antidepressant, but we're not using it in antidepressant doses. We're using it in a very low dose, and it does reduce hot flashes, but you can see 3.9, oh, I'm sorry, 3.9 versus 5.6 hot flashes per day. That doesn't seem like a lot, although patients in the trials did think that that was meaningful, and they did feel that it was an improvement. The good news is that over time, it had continued, if you continue to take it, it did continue to reduce hot flashes and help sleep, and was very well tolerated. And importantly, it didn't have an impact on weight or libido. You can't use it. It's contraindicated in patients on tamoxifen because of the way that tamoxifen is metabolized. There's other antidepressants, all of them, Paxil, Celexa, Lexapro, Effexor, Cymbalta, that do have data as being beneficial for reducing hot flashes. Again, the hot flash reduction is about 25 to 70% reduction. I will tell you there's a very consistent placebo effect of about 25 to 30%. So again, not dramatic compared to the 90 to 95% reduction with hormone therapy, but certainly they are effective. And I use all of them on this list for hot flashes. The big thing to remember is tamoxifen, there are drug interactions. Lots of breast cancer survivors are on tamoxifen, and hot flashes are terrible for the majority of women on hot flashes. They have a very specific metabolism, and so certain drugs interact. So specifically Wellbutrin and Prozac and Paxil are really contraindicated. The drugs that should be used in this class of antidepressants are Effexor and Pristiq if a patient's on tamoxifen. Gabapentin, also called Neurontin, is a medication we use all the time for diabetic neuropathy, for post-shingles pain, for chronic pain management. It works on nerves. It definitely reduces hot flashes, and it can be really a titrated dose for patients. The biggest side effects are dizziness and sleepiness and fatigue. It really does have a positive sleep benefit. So in patients who are having predominantly night sweats, I often use gabapentin because it can help with sleep. And the key thing is you should really start at a low dose. I have many patients who get put on 300 milligrams right off the bat at bedtime, and that can be too much for many people. They can feel really druggy in the morning. So I always start at 100 and go very slow. Combining it with an antidepressant actually does not help additionally. So in other words, you don't get a 30% reduction with an antidepressant plus a 50% reduction with gabapentin. It doesn't change, and so there's no value in combining medication. And this is something that you can use with a patient on tamoxifen. Clonidine, I'm just briefly going to mention because I don't use it at all. It's a blood pressure medication. The benefit in terms of improving hot flashes is small. It's not as effective as the antidepressants I mentioned and gabapentin. Interestingly, it's the only option that's approved in the UK. And it has a lot of side effects, including low blood pressure and heart rate, dizziness, constipation, dry mouth. Now, the other things that are out there that are not included in that 2015 position statement, but hopefully will be included in the updated one, are oxybutynin, stellate ganglion block, and then the new things that are in development. So oxybutynin, you may tell when I'm lecturing, my mouth is a little bit dry. That's the big side effect of it. Oxybutynin is a medication used for overactive bladder. Actually, the reason we learned that it was good in hot flashes was because oxybutynin is often used in men who have prostate cancer and overactive bladder related to that, and men who are on Depo-Lupron or anti-testosterone medication for their prostate cancer often have terrible hot flashes. And it was noted that the men who took the oxybutynin weren't as bothered by it. And so there are now 2 studies in women, and it is very effective. The biggest side effect is constipation and dry mouth, but it's completely non-hormonal. And you can also titrate it between 5 milligrams, 10 milligrams, and 15 milligrams. And I will tell you, having personally tried all of the different non-hormonal things at varying times, oxybutynin's been the most effective for me, and the dry mouth has been tolerable. Now, this is a graph just to let you see just briefly the difference in reduction in hot flashes between the varying things, and to show you that if you look at the far left where all of the bars start, that 100% people are having hot flashes, then all of these things go down. Placebo, it does go down about 30%, but you can see all of them go down in varying degrees, and oxybutynin appears to be the best. And so again, it seems to have the most benefit in terms of hot flashes. Stellate ganglion block, this is something I have not personally tried. It's an injection. You can see where it's injected into the cervical sympathetic chain. Not all pain specialists know how to do it. There are specific people who do this very well, and there's data about it reducing hot flashes. The problem is it only lasts about 6 months, and there's definitely risk to the procedure. And then in development are the neurokinin 3 receptor antagonists. And this is really all about this pathway in the brain. And this is very targeted therapy now. The data is coming. It looks very promising. And I'm hopeful that in the next year or 2, these will be available. There's also a specific type of naturally occurring estrogen with selective action in tissues. It's called a NEST or E4. So it's different than estradiol, which is the primary estrogen. It's produced by the fetal liver. It does cross the placenta, and it acts differently than estradiol. It doesn't have as much breast stimulation, but it's still good at the bone. And it's been found that it reduces hot flashes and very well tolerated. And this is another thing that's in development. And of course, no data at all yet of whether or not this would be something that a breast cancer survivor could take. I would say probably not, but it's coming up the pipeline. In terms of supplements, there's a million out there. I put some of the newer branded supplements on the right, the Bonafide line, Femoral, Amberin, Estroven, Goop, and Madame Ovary. There are lots of combination products with very limited data. I do have patients try them, and some patients seem to have some benefit. The problem is really no safety data in breast cancer survivors at all. So it's hard for me to recommend these supplements in my breast cancer survivor patients, because although they're not hormones, not everything that's over the counter still is safe. This is briefly just the same kind of graph to show you that all of the supplements that have been looked at here, so this is flaxseed, vitamin E, soy, they show reduction, but it's not fabulous reduction. It's not much better than placebo, and it's why we really have a hard time recommending them in addition to not good data in breast cancer survivors. And what about soy? Tons of evidence about soy that it does all kinds of good things, right? There's lots of data. So soy is a naturally occurring, obviously, soybeans and tofu. It is a what we call a phytoestrogen. It's very similar in structure to estradiol. And so it has similar activity in high doses. And so this is really, we've been looking to see if there is promise about this. Of course, there's been concerns about excess soy in breast cancer survivors. Now, there's one product, this S-Equal, that NAMS recommends with caution in that 2015 paper. And this is a very specific product that avoids the problem. Some women cannot convert soy into the molecule where really it has the effect. And so this kind of bypasses that. And there is some data about S-Equal or Equal, again, not data in breast cancer survivor patients. And so there's more data coming out about this and probably more recommendation in the next guideline. And then a couple last things. So wearables, there's all kinds of stuff on the market. So lots of things you can spend your money on in addition. Now, I will tell you, the company sent me one of the Ember Waves. I was very excited about that. I will tell you, I found it very bothersome. In addition to washing my hands a lot in the office, I just found it irritating. But some patients do like that. You can walk around with basically the fan and the cooling device and then the Menopause. I find these things cumbersome. I'm busy at work. And so not all that great, but some women do find them helpful. And then quickly, sexual health and survivors, and I have to go real fast because I'm out of time, but most survivors suffer from vaginal atrophy, and it's really a big problem. And this is what the anti-estrogen or menopause does to the vulvovaginal tissue of postmenopausal women survivors. And I see this all the time. And you can imagine if you're looking at that, you get complete atrophy of the vulvovaginal tissue. And that looks like sex would be very, very uncomfortable. And it's related to the loss of estrogen. So women complain of dryness, burning, irritation, pain with sex, and recurrent urinary tract infections are a really big problem. We know that even without breast cancer, that 80% of women will have terrible sexual dysfunction by 8 years after menopause. This is really common, and the majority of women are not getting treated. There's lots of options, dilators and pelvic floor physical therapies, as well as lubricants and moisturizers. There's vaginal laser out there, and then there's local hormone therapy. And again, in the interest of time, I'll go quickly through this. The first line therapy for anyone like our patient who can't take hormones because she's systemic hormones because she's a breast cancer survivor is really non-hormonal lubricants, moisturizers, dilators, and pelvic floor PT. So lubricants and moisturizers are different. Lubricants you use with sex. Moisturizers are something you apply like face cream, except to your vulvovaginal tissue. The more you use it, the more it can be helpful. And there has been data that if women can use moisturizers regularly, there is some benefit to it. It's not as good as using local estrogen, but again, I encourage all women, and there's several good products over the counter now, to get a good vaginal moisturizer and use it regularly. But local hormones, I just want to make sure you understand, are different than systemic hormones in terms of dosing and in terms of what our recommendations are. So for this patient who's a breast cancer survivor who can't take systemic hormones, it's not always the same that she can't use local vaginal hormones. And this is a publication, again, by NAMS and Ishwish that I was involved in developing a review of the data about local hormones, vaginal hormones in women with breast cancer or at risk for breast cancer. And I'm just going to explain, I skipped that busy slide to say that the local estrogen, so a year of local estrogen is equivalent estrogen to one single birth control pill. So the dosing is just dramatically different. But the problem is, because of the FDA, it still requires this package label. And it says, again, if you have any history of breast cancer, you can't use this. Now, this label comes from that Women's Health Initiative data study and really doesn't apply to the data in local vaginal estrogen. But again, we're stuck with the label. And so I talk to patients about that all the time. From the WHI, a separate arm, there's lots of data in 45,000 women about the long-term safety of vaginal estrogen, no increased risk of breast cancer at all. And when we look at the studies that led to the approval of these products, you can see that the hormone levels, when people are using these products in the bloodstream, don't change above menopausal levels, which is why these things are so safe. The dosing is so low that it's like a drop in the ocean. And vaginal laser is out there. I can tell you I have a vaginal laser that I use in my breast cancer survivors now very infrequently, because I really believe that, and I see that the local vaginal products work very, very well, and that many women can get away with using them very sparingly. And so finally, Karen, she's 48. She's having terrible hot flashes and sexual dysfunction. She's a breast cancer survivor. She's on Tamoxifen. How would I treat her? So you could talk to her about over-the-counter supplements such as Esequal, and it could be a consideration. But again, I'm not a supplement pusher because I don't like the fact that there's no data in breast cancer survivors, but I have a lot of patients trying these and I don't tell them that they can't. Because she's on Tamoxifen, venlafaxine or Effexor is usually the first option I will go to, although it has sexual dysfunction associated with it. So sometimes I will do oxybutynin as first line, which does not have sexual dysfunction associated with it. And gabapentin is fine. Oxybutynin and gabapentin you can use because she's on Tamoxifen as well. And then for her sexual dysfunction, moisturizers and lubricants, you definitely can consider local vaginal estrogen in conjunction with her oncologist. It's a completely different animal than giving systemic hormones, and certainly lasers an option as well. So I thank you. I rushed through a lot of information. I hope you found that helpful, and please reach out if you have any questions. That's my email that you see there. Thank you.